This is actually Gleason pattern 4 prostate cancer. So under the microscope, these look basically identical. So same classification by our current system, Gleason grade. But it turns out that these individuals went on to very different long-term outcomes. In one case, there was a cure. In another case, this cancer was fatal. It had already escaped. So our current classification system really couldn't distinguish between those different outcomes. So we were imprecise in how basically could we or should we approach treating these individuals differently. So the idea of precision medicine really thinks about it like this. So there was a National Academy of Sciences panel convened to think about, not only in cancer, but in all of medicine, can we really rethink more precisely how we diagnose, how we follow patients, and impact their care. And probably the simplest way to think about what is ultimately a very complex problem is to think about Google Maps or map-type programs that you use probably commonly, where you have different layers of information here. So Google Maps is pretty remarkable because you can get an actual image of your own house and your own street, and that's overlaid, for example, with topography, so height. You have postal codes, you have the bus network, transportation, et cetera, that's all integrated into a very useful tool. So this is really where medicine is going. We're not quite there yet, but thinking about overlaying a patient's signs and symptoms, their environment, what kind of drugs they're on, what kind of treatments they're having, and then getting down into the really drivers of their cancer, what genes are turned off and turned on, what inherited genome that they might have. So from a patient standpoint, we ultimately want to layer all of this information so that we can define the disease really based on its intrinsic biology, not just what it looks like under the microscope. So there's a lot of context for how we would use this. We've heard talks this morning about the importance of heritability, so you may better understand risk to impact how you might prevent cancer, how you might counsel a family, and understand side effects and toxicity of therapy that clearly also can be heritable, how you metabolize drugs. And then from a tumor standpoint, determining how that tumor is going to behave, what it's going to be vulnerable to specifically, and then in terms of treatment resistance, being able to potentially predict that. So we now know that prostate cancer comes in many, many different flavors. By flavors, I mean the genetics or the genomics, the mutations, the rearrangements of chromosomes varies tremendously from individual to individual, from tumor to tumor. I'm showing you here simply a map, now a bit outdated, from maybe 5 years or so ago, just looking at one type of gene rearrangement. And this was really quite fascinating because it takes a cancer gene, which is usually off. It's not active in prostate cancer, but there's a rearrangement in a chromosome, a break, and then two genes are fused or put together to take this cancer gene and hook it up to the androgen receptor driver. So you heard from Dr. Mostagal how important the androgen receptor is because it turns on certain genes that then can fuel cancer growth. This is an example that only occurs in the tumor where you have this chromosomal break. And it turns out in prostate cancer patients, there's at least 20 different subtypes of this single break. So it's a very complex rearrangement. The question is, are there also 20 different vulnerabilities? Can we target particular drugs to these alterations and mutations? So there happens to be some laboratory data that says if you have this particular change, this particular rearrangement, ERG being the cancer driver gene, T2, can think of it as the Terminator, I suppose, being turned on by testosterone, turns out there's laboratory evidence that this particular class of drugs, called PARP inhibitors, kill these tumors very effectively. So that was in the laboratory, and there is now a clinical trial testing that idea. So for patients, if they're found to have this particular alteration in their tumor, they're being treated with this particular class of drug, the PARP inhibitor, to determine if it is predictive that tumor will respond. So that trial's underway. There are about 100 patients now enrolled, and it'll probably read out in about the next year. So we have a very large effort now to fully assess, fully identify the entire landscape of genomic changes in advanced prostate cancer. This is called the Castration-Resistant Prostate Cancer 500. We're going to be looking at 500 patients. It's supported by the Stand Up to Cancer Foundation as well as the Prostate Cancer Foundation. So we're about 200 patients into this, and we've already started to learn certainly what the most frequent, what the common molecular events are in advanced prostate cancer, and we're also finding unique ones that looks like they occur only in a single man at this point, but interestingly, a number of these changes occur in other cancers that affect others, such as breast cancer, melanoma. So we're starting to think about using a breast cancer drug now to treat that prostate cancer patient if they have that particular alteration. Built into this CRPC 500 to identify the full landscape are also a number of these clinical trials using a drug that would specifically hit an individual target. One of the things we've learned just over the last 2 years is that although prostate cancer generally has very few actual mutations or alterations, it turns out that there's a subset of patients here with these very high peaks that are hypermutated. So what I'm showing you here are about 50 patients and multiple tumors from each of those patients, and we're simply enumerating the number of mutations that occurred in that cancer. So in most of these prostate cancers, there's between, say, 50 and 100 mutations. But in a subset, you can look at across these 5 individuals, there's up to 1,000 mutations in those tumors. We know now from studies here that I won't get into what the cause of this is. What we don't yet know is whether these patients are vulnerable now to a specific drug, whether their tumor would be killed. We're starting to test that now because this has parallels with certain types of colon cancer and endometrial cancers that have particular susceptibilities. So this is all well and good. We've done a lot of research here. The question is, can we get this into the clinic? Is there clinical utility? And then will it actually improve the outcomes, which is where we want to go. So with this large project, this Stand Up to Cancer CRPC 500, we're actually testing this precision medicine idea. So in the old days, we would convene tumor boards where if a patient was diagnosed, we want to try to develop a treatment plan for them, so we bring a lot of heads together. We bring in a medical oncologist, a urologist, a radiation oncologist, a pathologist. We bring in all these people, sit down together in a room, and review the patient's history. We review what their stage is, what their pathology looks like, et cetera, and try to provide a consensus opinion. Now we bring in a whole new dimension. So in this multidisciplinary sequencing tumor board, we have the oncologist, but we now need to bring in a genomics expert to interpret and help understand, does this mutation confer susceptibility to a drug or maybe a clinical trial that would be appropriate to target that drug. And we also need to bring in clinical geneticists. That is that when we sequence the tumor's genome, we also sequence the normal genome of that individual, and we may find things, in fact we do, that have implications for other dimensions of their health and for their family members. For some things, those would be actionable. You could do something about it. But for other things, we don't have a particular treatment. Hence, they need real genetic counseling to help interpret that. So I'll give you one quick example of a case, a recent patient here that we saw. This was a man with high-grade localized prostate cancer that had been treated with external beam radiation therapy and then recurred locally. So he ended up having biopsies of his prostate that showed recurrence and then had surgery and actually resected that tumor. Now, at the University of Washington, we've developed a panel of cancer-associated markers that's called Oncoplex. So it distills the entire genome, which is 3 billion letters, into a set of about 200 to 300 genes that we think at this point are actionable, this tier 1, so we have drugs that would specifically interact with them, others that we think are actionable in the near future, and then others that we think are frequently mutated, and we need more evidence to try to motivate groups to develop drugs to treat them. So this particular patient underwent this Oncoplex test, which the beauty of it is it's actually a clinically approved test now. So it's done in a format that has very rigorous quality control and can be reported back in the medical record. It's not simply a research tool. So this tumor was sequenced, and these were the key findings. So that gene rearrangement that I told you about that has the androgen receptor-driven gene along with the cancer gene, that's this TMPRSS2 ERG fusion, this tumor was positive. It clearly had evidence of that rearrangement. It also had a striking change in another cancer driver gene, this PIK3R1. The essence of that isn't really important, the nitty-gritty, other than we know from experience, from laboratory studies and looking at other cancers, this is clearly a gene that drives tumor cells to grow. And importantly now, in clinical trials, there are drugs to treat that. And here's the specific mutation that occurred in that particular gene, and we know that that mutation drives that gene, turns it on, makes it active. This is that entire genome from that patient, chromosome 1 through chromosome 22. Here's X and Y. And you can see that this genome has many, many alterations in addition to those mutations that I described for you. And here's another critical gene, this P10, which is lost and also is a cancer driver gene. So the take-home message after we had a sequencing tumor board to provide advice to this individual, this cancer predisposing gene we believe is targetable with a number of drugs that are in clinical trials, and this particular alteration that I mentioned for the PARP inhibitor trial, this patient would be eligible for both of those studies to test whether these drugs will actually be more specific for his tumor. So just to end here, this cancer genomics piece is part of a large effort that we have called Act Smart, which includes a 6-part program to really tackle prostate cancer from several different dimensions, from the educational piece that we're providing for you today, as well as this genomics and precision medicine component. And the goal here is to more precisely determine which drugs will work better in which patients, which drugs we shouldn't be using because they'll only cause side effects. But we're now faced with a large number of new therapeutics coming online, and what we really don't know at this point is how do we sequence them, what are the right combinations to use, and we're hopeful that this more precision medicine will provide that advice. So to end here, what we'll have in the very near future, in the next 18 to 24 months, is really a complete encyclopedia of the common molecular changes that we believe are driving advanced prostate cancer, a subset of which we can target now, a larger subset of which we can't target yet, but it will be the fuel for drug development. We'll know for a couple cases very soon whether these specific vulnerabilities actually respond better to therapy. So I mentioned there's 2 clinical trials underway now. These should read out within the next 2 years, and there are many more to follow. And then the third status point here is the identification of new treatment targets based on understanding resistance. So not only will we be looking at one time point, but we'll plan to look at multiple points over time as tumors respond or resist therapies. So that's really the end of this discussion. I'll be available to answer questions as well, but I'll introduce our next speaker because this is also the evolution of where we want to go. Everything I've described for you now requires a biopsy of the tumor, whether it's a localized prostate cancer that you might sample by biopsy or at the time of surgery, or in a case of advanced prostate cancer, we have to go in under image guidance like a CT scan and get a biopsy. The future is to try to ascertain the molecular changes in a tumor without invasively having a biopsy, and that is, can we find markers in the blood of patients, whether they're circulating tumor cells or DNA that may be in the blood, to be able to assess what molecular changes occur rather than having to invasively go in and get a biopsy. So our next speaker is Dr. Heather Cheng, who's an assistant professor here at the University of Washington and the Fred Hutchinson Cancer Center, and she's been doing some very interesting work in looking at circulating biomarkers of prostate cancer. So, Heather?
Thanks very much. Can you all hear me okay in the back? All right. If you can't, then just let me know. So let me just start. So just to orient you, I know there have been a lot of talks today. I just wanted to remind you that today I'm going to be talking about biomarkers in advanced prostate cancer. So we already heard about it in the localized disease setting. And just to orient you, there's, in some cases, we have a rising PSA after definitive therapy, and people can develop metastases or hormone or castration resistance, and that leads you to advanced prostate cancer, and that's the disease setting I'm going to be talking about today. So as Pete mentioned, or Dr. Nelson mentioned, we're very fortunate right now in having a number of new exciting FDA-approved treatments for advanced prostate cancer. This just is a timeline of some of the new agents and when they came out. Docetaxel came out in 2004. It's a chemotherapeutic agent. And then Dr. Steffen talked about immunotherapy. We have the Sapulus LT, which is commercially available, although hopefully we'll get some improvements on that in the near future. Cabazitaxel is the chemotherapy. We have abiraterone, which Dr. Mostegel talked about, as well as enzalutamide. And then the newest kid on the block is radium-223, which is a radiopharmaceutical. And then Dr. Montgomery is going to talk after me about some of the new agents that are currently in clinical trials here at the SCCA and University of Washington, so I won't go into that. But the bottom line from this slide is just to say we have a lot of new treatments now and more coming in the pipeline, so this is really exciting. And as Dr. Nelson mentioned, the challenge for us is how to maximize the benefit to you and how to figure out sort of what order and which treatment is best. So just to step back a little bit and give you a definition of biomarkers. What do I mean when I say biomarkers? So this is from the National Cancer Institute NCI Dictionary of Cancer Terms available on the web. So biomarkers are defined as a biological molecule found in the blood, other body fluids, or tissue that is a sign of a normal or abnormal process or of a condition or disease. So it can be used to see how well the body responds to treatment for a disease or condition, and sometimes it's called a molecular marker or signature marker. There are a number of different cancer biomarkers. I just want to review some of the different functions. So the first class, or the first category, would be a prognostic biomarker. And those are markers that tell us, is your cancer likely to be aggressive or not? And we have Gleason scores in localized disease to help us determine this, and PSA can be helpful in this. When you first are diagnosed, we use these to guide and counsel you as to whether your cancer, is likely to be aggressive or not, and what treatments might be appropriate in that scenario. A second class of biomarkers or characteristic of biomarkers are response biomarkers. So is the treatment that you're receiving useful or telling us, is the treatment working? Is it not working? Do we need to try a different treatment? So there are response biomarkers. And then the final category are predictive biomarkers. And this is really the most exciting category, I think, for us today. And those are markers which can tell us which treatment is going to be or is likely to be the most effective in fighting your cancer. And so Dr. Nelson talked about precision therapy, and this is really the future and what we're most excited about, trying to find biomarkers, predictive biomarkers, first in the tumor, but hopefully ones that we can get from a blood test in a non-invasive way. So you're all experts in at least one circulating biomarker, and that's PSA. PSA, as I alluded to, can tell us information about your prognosis and also how your treatment is working, but it doesn't really tell us what treatment we should try next. So So just again, can we find new biomarkers that can be more informative and less invasive? And so some of you may have seen this article this week, actually just 5 days ago in the New York Times by Andrew Pollack, and I would recommend it if you haven't read it already because I found it pretty interesting. But it goes over some of these, new circulating biomarkers that people are studying. The article focuses more on breast cancer, but it is interesting and informative, so I would check it out if you haven't already. Okay, so there are a lot of different types of circulating biomarkers, things basically molecules or cells that we can measure in the blood. Do I have a pointer here? Let's see. Oh, here we go. Okay, so there's circulating tumor cells, so that's if we take your blood, can we measure any microscopic prostate cancer cells in the blood? And those are, at this point, we can measure them or we can count them, and I'll talk a little bit more about that in a second. We can also look in the blood for remnants of cancer cells or remnants that from the tumor or from the cells that have escaped into the blood. So you can either measure the cells that have escaped or you can measure the DNA or their skeletons, so to speak, that are in the blood, or other evidence, microRNAs, which I'll talk about more in a second. The important thing about this is not so much, I guess the concept is just that we can detect these in the blood. And I'm not going to talk about protein biomarkers, which also could be detected as well. So these are cells and nucleic acids. Okay. Oh. Okay, so some of you will recognize Dr. Montgomery. So in 2008, this was the first, or one of the seminal papers for circulating tumor cells. This is basically a study which showed that men who were about to start a treatment had this test, which is to say they had a blood test. They took 7.5 mils out of blood, and they looked for evidence of circulating tumor cells. And if they found them, they counted how many there were. So the green graph is the survival of patients who had less than 5 detectable circulating tumor cells in a 7.5 mil sample of blood. So if there was less than 5, they did better. If they had more than 5 or more, I should say, they did worse. That's the red curve here. And so these curves you can see are pretty far apart, meaning those groups really are separated. If you have less than 5 or more than 5, it really tells us about how you do. And based on this study, the FDA approved the use of Cell Search or Veridex for monitoring patients who have prostate cancer. So some of you may have had this test already. So this is available. This counts the number of cells. It doesn't, so it tells us prognostic information. Okay. So it tells us, is the cancer likely to be aggressive? It is, because we know that there's differences in survival. It doesn't, it also, although I won't show you the slide, give us information about whether the treatment is working, because there was some evidence that once you started therapy, if the number of tumor cells that you could find went down, it was suggested that you were responding to therapy. But it does not yet tell us which treatment is going to be most effective in fighting your cancer, although at this point there is a lot of effort ongoing to try to characterize the cells themselves. So not just to count them, but to look for those molecular changes that Dr. Nelson was talking about within the cells. So that's the future. Okay, so I talked to you about the circulating tumor cells, and now I'm going to talk briefly about microRNAs, which is my area of research. So a few basics on microRNAs. Some of you may or may not have heard of them in the past or before, but they are short. They're 22 nucleotide long non-coding RNAs. There's about 1,000 of them in the human genome that have been characterized. They have wide-ranging biological roles, and they're misregulated in cancer. And the important thing from your standpoint and from the standpoint of discussing biomarkers is that they're detectable in the blood, and cancer-associated microRNAs in particular can be detected in the blood. So they're promising biomarkers. So how do we identify a new microRNA? If we're thinking they might be useful as biomarkers, how do we know if they could be? So this is just a concept slide, but this is how we began our efforts, and that is we took 25 volunteers who did not have prostate cancer, and we took some of their blood. These are volunteers, and this is part of this was with the help of Bob Vassell and Carl Marcy, who have a great resource here at the University of Washington. We have a biorepository, so volunteers who volunteer to, give up some blood, extra blood samples, this gets stored here. And so this is one way we use, when you volunteer, this is one way we use your blood. So 25 volunteers without prostate cancer, 25 volunteers with advanced prostate cancer. These guys have a few more hurdles to jump over, but they're otherwise doing okay. So what we do with those blood samples is we pool them, or we pooled all of the blood from the healthy patients and all of the blood from the volunteers, and we compared those pools. And we looked for microRNAs that were either and we compared the levels. So if they're on one, or if they're the same, that means there's no difference between the two groups. If there's the microRNAs below the line represents ones that were lower in the cancer cases compared to the controls. The ones that are higher are the ones that are higher in the cancers compared to the controls. So it just gives us an idea of the separation between the two groups. And I'll just tell you now, here are some of the initial findings. We then had to go down, confirm those findings, and so some of those dropped out. I won't have time to talk about each of these, but I will just mention that the ones that did validate were known or are known to be involved in important cancer processes such as epithelial mesenchymal transition maintenance, neuroendocrine transformation potentially, and hypoxia response. So there are some interesting biological functions for these microRNAs as well. When we took the blood of those 25 volunteers that did have cancer, and we went back and looked at what their clinical history was and what their treatment was and whether they were responding to their treatment or not, what we found is that the pre-treatment levels of a particular microRNA, 210, is associated with a response to therapy or a non-response to therapy. And so what that means is, if we took the blood before you started treatment and we could tell that your levels were higher or lower, it suggests that maybe it could tell us if that cancer is likely to respond to the treatment or not. Now, this is a retrospective study, which means this is historical samples that were banked from the past, so it requires more study. But this just suggests that these are interesting molecules to study, and they might be able to help us identify different populations of patients using microRNAs. So the next slide, so the next thing to do is to try to study these molecules, microRNAs or circulating tumor cells, in a clinical trial, a prospective clinical trial, one that's moving forward. So this is a trial that we're studying. Some of you may have been enrolled in this trial, SWOG 0925. It's been now completed accrual, but Evan Yu, who spoke earlier today, it was the national PI on this study. It was a multi-center study, and Dr. Plymate's research really fueled the rationale behind the study. So the main idea is that the patients enrolled were ones who had newly diagnosed metastatic prostate cancer. They were randomized either to the standard treatment of androgen deprivation or androgen deprivation plus this experimental agent called IMCA-12, and they measured PSA and long-term survival. And a subset of those patients volunteered for the correlative science arm of the study, or it was voluntary. The secondary part of the study was that they would give extra blood to evaluate for circulating tumor cells and also for microRNAs and other studies. And so this just gives you an idea of how, when we ask you, when you're on clinical trials and we ask you for blood samples, this is how we're using it. And also, for example, in other studies, when there are metastatic biopsies, we may request both the blood tubes and also biopsy tissue, and that's sort of how we use those samples when you donate and volunteer those. This is sort of the summary slide, circulating blood-based biomarkers in a glance. So I talked about PSA briefly. Is it prognostic? Yes, to a point. Does it help us with understanding your response to treatment, yes, to a point. And some of you, actually, I talked to someone at the lunch break about the fact that, really late in disease, PSA becomes less useful, but it's the best we have right now. So is it predictive? Does it tell us which treatment will be effective in fighting your cancer? Not really. And I talked to you today also about CTCs. At this point, we know them to be prognostic. We know them to be helpful in understanding response. There's a lot of active investigation in trying to figure out if they can help us with predictive information, and the same is to be true for microRNAs as well as circulating tumor DNA, which I didn't talk as much specifically about, but the idea is the same, which is that the hope is